name is Craig Hellemeyer, and I'm part of the Child Health Advisory Council. And as we put together this webinar, we're going to have contributions from many members of the Child Health Advisory Council. Today we have with us Bruder Stapleton, Danielle LaRoccarina, Robert Sawin, Arnold Strauss, and Chris Gleason, as well as faculty and staff from Career Physicians, Wes Milliken. So today we're really going to be talking about clinical outreach programs, or regional programs as they're oftentimes referred to. And we have lots of experience on the panel. These programs certainly come in all shapes and sizes, and different shapes and sizes oftentimes have different challenges and different ways that they can succeed. And the first thing I think that I wanted to really focus on in today's discussion is, what are the factors that we should be considering as we develop a clinical outreach program, and how then are we going to go about determining its success? Chris, did you have anything you wanted to say about this?
The question you posed has some different applications depending on what kind of outreach or regional, as you called it, or community program you're talking about. And my experiences with neonatology, which probably does differ somewhat from others, but I certainly have had a lot of experience with that, as have most neonatal leaders, and because it's been very competitive for the last several decades. And hospitals, as you well know, all of you leaders on the call know that most pediatric departments, probably a good number of medical schools, depend on neonatal intensive care unit revenues to support all the myriad aspects of their mission. And so developing these regional programs in neonatology, or community programs, outreach, most of the time in large communities, it's competitive, large where the main, mothership is. It's competitive with private practice groups and including obstetrical groups. But I think the measures of success are, in my view, when it's been successful, it's been because the overall purpose of the program is to improve the outcomes of pregnancy and improve child health. And getting that culture and the associated financial implications and academic implications to the faculty and the faculty leaders, all aligned with the hospital's needs for the financial revenue, in this case NICUs, but certainly in cardiology programs, surgical programs. I know Bob can speak at length to that. I think getting that aligned, particularly if you're searching for a leader or starting a program, I think that's the real challenge. But if it's done right, it meets the needs of the community and the patient population, and the academic, the faculty, and the hospital and the leadership are behind it, that's what's going to determine the success of the program.
Great. Well, thanks, Chris. Arnie, I know you've had a lot of experience heading up large programs at large children's hospitals. Can you give us some perspectives on this?
Thank you, Greg. So I'm a cardiologist and have been doing outreach programs for 40 years, mostly in situations in which leading children's hospital is in a major metropolitan area, but services an area with a fairly extensive rural community. So what are the goals and why set up and where to set up such clinics? And I'm talking now, in contrast to Chris, about outpatient clinics. The goal is to provide service to the patients and their families. In that increases the access that they have to subspecialty care. So it's both for initial evaluation and for follow-up, and I think those are important. That is, it's not about a particular high-end procedure. It's about initial evaluation and then follow-up locally so the family does not have to travel. I grew up in a small town. Small town people don't like to go to the inner city, and being there in that community is a real asset to the families. It's also a major asset for the practitioners in the area, whether they're pediatricians or general family practitioners. It provides them with an easy ability to test their families, to have diagnoses made in their families. And they love it. They love the ability to be able to have someone in their community who has the expertise to augment what they already do. So I think, so how do we decide? I think it's based on two factors mainly. First is it wanted and is it needed? And that means that there has to be someone who, often a hospital or a pediatric group, who has the connections to your institution that will allow them to participate in the clinic. And then I think it's really important to assess the population and the demographics. You need to know where your patients might come from. You don't want to go to a very small town. Well, there won't be very many patients. You want to go to a center, a sub-center area where there's sufficient numbers of patients to be efficient. And not too many, but not too few. So I think demographics, interactions, and the basic understanding that this is a service to the community and to your patients.
Great. Bruder, I know you've also had lots of experience in dealing with clinical outreach programs and regional programs associated with your large children's hospital. You want to give some insights on that?
Sure. I think each of us on the panel have had experience, and our experiences all differ. There's outreach within an urban area. There's outreach in a state, and in Seattle, we were the tertiary care center for 4 states. I think many of the points are still the same. First of all, the community you need to work with the community to decide there is a need, and your services would be beneficial to that community. I think that's really critical. And many of the points that have been made, the geographic location in a wide area. For instance, I'm a nephrologist, and many of my patients were on the other side of a mountain, and they couldn't even get to the tertiary care center during the wintertime. So that I think, working with the communities, understanding the need, and also understanding the capability to provide those services. What kind of services are you going to be able to provide? So you have to partner to do it effectively with your institutions, either the university or the children's hospital. Many services, diabetes, to serve a diabetes population at a distant location, you need a lot of ancillary services. And are those going to be able to be provided at that site? Secondly, having a culture where people recognize that the mission of your organization is to serve whatever area you're going to, and that things like philanthropy and other things are going to be continued to be offered to patients even if they're in another state. You're not just going there to make money, you're going there to serve a community, and that you'll provide those patients you see at those distant sites with the same type of services you would if somebody came to your office. So I think those are really, really important things. So partnership with the community and partnership with your own organization, so that you'll have your doctors will have the support, your faculty will support the issue, and the community will support the clinic.
One of the things that I've always been concerned with as you begin these clinical outreach programs and try and establish regional presence, oftentimes we're dealing with faculty who've always been in the academic medical center. And sort of under the subtitle of "Can you teach an old dog new tricks?" How does one generate enthusiasm amongst faculty to participate in these programs? Or is that a bridge too far? Maybe we can't do that. Thoughts on that?
I think one of the challenges is how outreach programs are viewed. And as I was listening to the conversation and Arnie's point about what are the goals, I think most academic institutions have a multitude of goals that include clinical goals, teaching goals, educational goals, and research, which is important, and certainly responding in terms of advocacy, et cetera. I think it would be important to get enthusiasm of the faculty and others to know that not only do we want to provide the same level of care, and we're going to have to do cost, assessments, et cetera, but that we also want to expose our learners who are going to be the future folks to serve those communities in that process. Service learning is the term that is used, so that we don't see this as a marginalized piece of our operation, but central to our operation. We talk about research that doesn't have recruitment of underrepresented populations. Why? Because of access issues, the same access issues. How do we integrate wonderful research and the involvement in clinical trials to folks who don't have access? So point being, get faculty engaged in the process of what are the models of care that we want to put out there, and how are we true to those models and to the communities that we serve.
Thank you, Danielle. Bob, as a pediatric surgeon, what sort of issues have you seen involved in recruitment to clinical outreach programs?
In my own experience, we as Bruder mentioned, Seattle Children's is the tertiary care center for a wide geographic area, the so-called WWAMI region, Washington, Alaska, Montana, and Idaho. We had an opportunity to cover the sole pediatric surgeon in Montana for quite a while. And what I and most of my colleagues learned was that the quality of care provided in this small to medium-sized town in Montana was actually quite good. And it was sort of an eye-opener. It brought us down out of the ivory tower a bit to realize that there's a lot of good doctors in these communities, and they provide really good care. One of the challenges for surgery is the availability of reliable anesthesia, anesthesiologists who are comfortable, ideally trained in taking care of children. And that is a rate limiting step sometimes for the procedural specialties like surgery. And yet I found that there are in many of these communities anesthesiologists who had some additional training or who over decades of experience are quite comfortable and quite proficient taking care of children. So that was a real eye opener for many of us. One thing I did want to bring up, the communities typically want to have some consistency. What they don't want is 7 pediatric surgeons rotating in a different one each week. And so that can be a challenge sometimes to have someone who can become the constant, if you will. I think it's important for those relationships in the community that you have someone who's there fairly often. Obviously, you have to be able to provide them back coverage, but I think that continuity is something that's highly valued by the community. And then the other part of that equation is that if you do happen to hire someone who is based in that community, but has a relationship with the tertiary center, it's important that that relationship is real and that they periodically have the opportunity to come back to the tertiary medical center and see what's new and interface with the trainees. And so it has to be a two-way street. But I largely have found these experiences to be very positive. And once, in our case, once the surgeons had the experience, I think they found it to be a positive, and getting them engaged didn't seem to be a huge challenge.
Good. Arnie, did you have some thoughts on that?
Yeah, two thoughts. First, I want to emphasize what Bob just said, which is continuity. So when we had an outreach clinic, we tried to always have the same person go to that site so that they could develop those relationships with the referring both physicians and the office. And then I want to get back to what Danielle commented about. So what we did was to take with us a resident and fellow along with technical and nursing assistants as a team. And that team really became cohesive and garnered a lot of togetherness because of that. So that was an unseen benefit. But for the residents and the fellow going to these outreach clinics, when they're the first people to see a new patient, is a very good learning experience. The diagnosis is not made. They have to explore. And so they learn very quickly what's key in terms of making a diagnosis. So the learning experience was actually very strong. And then, of course, it also helped them learn how important it is to interact well with people that you may not see every day, people in the community that may be a little different than you are. And so I think it's an incredible learning experience for the trainees.
Yeah, I always found that when I would see a patient in a clinical outreach program that was maybe 100 miles away from the medical center, it just felt like a different experience for me. I felt like I was much more part of the community. I was much more likely to pick up the phone and to call the referring physician than I would have been at the academic medical center. It's just a different experience. I know, Chris, you've talked a little bit about some other ways that you might be able to make sure that you have faculty who are really committed to being involved in outreach programs. You want to talk about that a little bit?
Well, again, thanks, Craig. I do think that it has to be, in order to get them enthusiastic about it, it has to be part of the culture and part of the mission. And that has to be aligned with the hospital and the other academic, centers. Danielle and others have talked about education, somehow tying it to the educational program and not having it be sort of out there and unrelated, I think is a mistake. So again, in neonatology, it's sort of Bob mentioned too, the inpatient versus the outpatient clinics. I'm a strong believer, as several have mentioned, about continuity. And so for an inpatient, having somebody, especially if it's geographically quite distant, as you mentioned, Washington State, the neighboring states and so forth, if the outreach program or one of the regional NICUs is actually, too far to drive, well, then you're going to have a medical director who is out there and probably lives there or lives nearby. And having that be part of, not just in name only, but part of the division or part of the department and part of the educational program, I think is really key to encouraging faculty who not only want to do that, if you're recruiting somebody to be that medical director, but actually be part of that rotating group, say of neonatologists, or if you're going to have your follow-up clinic, have a satellite site out there, or as has been mentioned, one of the programs that I was involved in, there was a traveling team, just as Arnie mentioned, for follow-up, or, it was follow-up of some of the transport calls that came in where babies were sent out, to the mothership, but then came back for convalescent care or further cardiac follow-up or surgical follow-up or whatever. And we would have a team of a fellow and the attending, go out there on a monthly basis, if that was the case, for follow-up. Lectures would be given, and you got to know people. And so that was a very important part of encouraging. I agree with Bob. For the most part, that was viewed very positively by the people that went and did that, or interacted with that medical director when that medical director came back to the mothership to do an attending rotation. And so I think those are all, it's been mentioned by everybody else, but those are important ways I think that you can encourage, and it could be continued with the outreach programs, even in neonatology, because of NICU follow-up clinics and that sort of thing.
So making it part of the recruitment process, and it really is an important way to make sure our programs are embedded in the communities, and even a way to begin to understand the issues that those communities are facing is a really important thing.
Very important.
One of the things I wanted to make sure we touched on are, what are some of the challenges and or easy missteps to make in establishing clinical outreach programs? I know myself, we would oftentimes, at least initially, begin to not understand some of the compliance issues that have to be taken care of to make sure that you're renting space on a fair market, and that you're not doing a stark violation in terms of space for referrals and the like. And that can be an issue to pay attention to, making sure that billing is taken care of, making sure that patient satisfaction is adequately measured. What are some of those other things that people have noticed in clinical outreach programs that you need to be especially aware of?
I think someone referenced it earlier, the volume of patients, particularly in the beginning, might be low enough that productivity as measured in the traditional sense might not be reasonable. And so the institution has to be willing to accept that and to give credit, if you will, for the lost time, quote unquote, of productivity that surgeon may have had were she or he, based back at the mothership. If they're going to travel and spend a half day traveling to do a half day clinic and see only 3 patients, that's still a valuable service for that community, and may build to the point where you're seeing 6, 7, 8 patients. But in the interim, the measure of productivity needs to be adjusted.
To me, outreach is great for health systems, and outreach is great for departments. And I think it's inherent on the leader to really make sure that it's incorporated as part of the culture of their department or their division. A lot of outreach currently in the U.S. in pediatrics is being done by the more senior members of a division because they have been doing it forever. And, I know a lot of the faculty I worked with at Seattle Children's have been going for 20 plus years to Alaska and to other places, but it really hadn't fully been passed on to the next generation. And I bring that up because the new generation of physician coming out, quality of life is a really big thing, as we know, and they may have selected a role that didn't involve outreach because of the fear of how outreach might impact their quality of life. And so, those are dynamics with the people we've recruited, and making sure that they see it as part of the mission, and that we do everything possible to make sure it's not taken as a bait and switch, if you will, as a leader, if you're going to then require somebody to go to outreach that wasn't recruited to do so. So just some things that we've heard from the candidate's perspective that would be important.
Bruder, did you have any final comments you wanted to make on that?
Just to follow up on what both Bob and Wesley said, it's really important to have a financial structure that doesn't disadvantage a faculty member from going out. We had a system, I won't go into the details, but recognize that the work they did was just as important as their work at their usual clinic. And we calculated what an individual would generate at a usual clinic, and then applied that at the outside clinic if it was not, if there was a deficit. We also incentivized travel so that it was not a disadvantage to a faculty, and it was an advantage. Secondly, if there is an adequate, as it builds up, need or a geographic imperative, having someone located in those areas is also very helpful. For those faculty often have families. It's hard for them to travel if it requires overnight or even a long day away from family. So thinking about those things and providing childcare, working with the faculty to find out what their needs would be if they did that, and trying to support them would be really important, because it may be an advantage to the community, but it may be a real stress on the faculty member going out there. So really working with both sides to make it a successful partnership.
So that's a really good point. In fact, sometimes maybe you even have to provide incentives for people to do off-site clinics because of issues like that. Yeah.
I wanted to end on a positive note. I think clinics were one of the best experiences that I've ever had. I really enjoyed doing them. I enjoyed getting to meet the people. I enjoyed traveling with the team. And I think that excitement can extend over to others. So with our clinics in St. Louis, some 15 of them, I never heard a word of regret about doing it from any of the faculty members who did it. They loved going. They loved seeing the new environment, and they loved doing something different. And probably they loved getting away from me. So I think it was a very positive experience for most of our faculty. But I do think you need to be aware, when you recruit people, they need to be aware that you're expecting this down the road.
Yeah, and I might even add, this is sometimes an example where leaders in pediatrics can show their leadership by actually being involved in the process. And I know as a chair of pediatrics, I tried to make sure that faculty knew that I was involved in the clinical outreach program, and I wasn't just sitting there talking about it happening.
Craig, I was just going to say, I agree 100% with what Arnie said. And I think it's a kind of a key point for leaders in pediatrics as they're dealing with their own outreach scenarios to really look at your faculty and your staff, and are they excited? Are they happy? Are they enjoying it? And I think if they aren't, then it's just a signal. Arnie, I really appreciate it, because I do agree with that. I think people that it's set up right love it. So I just thought that was an interesting, like, little tidbit, leadership tidbit that one could use to determine how their programs are doing. So
No, I just want to thank all of my colleagues for the discussions that we've had on this. It's really been very interesting for me. And I think that it shows the value that a well thought out program in clinical outreach with some parameters of success that you need to make sure that you evaluate on an ongoing basis can really be a win-win. It's a two-way street. You're providing value and access to the community, but you're also providing some joy and some fulfillment for the faculty members that are participating in it, as well as the team spirit that can come about. So thank you all very much for your participation.